The Midlife Body Reset, a woman's guide to metabolism, bone health, and thriving after 60. For many women, the menopausal transition brings a frustrating sense that their body is no longer playing by the familiar rules. The diet and exercise strategies that worked for decades suddenly seem to fail, leading to weight gain, new aches and pains, and concerns about long-term health. This is not a personal failure, but a predictable outcome of a fundamental shift in the body's biological blueprint. The loss of key hormones rewrites the rules for metabolism, body composition, and chronic disease risk. Understanding this new physiology is the first step toward abandoning ineffective old strategies and adopting a new, evidence-based approach to building a strong, resilient, and healthy midlife body. This guide provides the essential truths and actionable plans to manage your physical health, mitigate long-term risks, and become a powerful advocate for your own well-being. The Midlife Metabolic Reset, rewriting the rules for your body. One of the most common and frustrating experiences of the menopausal transition is the sense that one's body is no longer playing by the familiar rules. The diet and exercise strategies that worked for decades suddenly seem to fail, leading to weight gain, particularly around the abdomen, despite no changes in habits. This is not a failure of willpower or discipline. It is a predictable outcome of a fundamental shift in the body's metabolic blueprint. The loss of key hormones rewrites the rules of energy balance, body composition, and fat storage. Understanding this new physiology is essential to abandoning ineffective old strategies and adopting a new, evidence-based approach to building a strong and resilient midlife body. The new biological blueprint: why eat less, do more cardio fail. The conventional wisdom of eat less, do more cardio for weight management becomes not only ineffective, but potentially counterproductive during menopause. This is because it fails to address the three core physiological changes that redefine midlife metabolism. The frustration women feel is a direct result of being given the wrong tools for the job. The old advice can even be harmful, as excessive calorie restriction and cardio-only exercise can further catabolize precious muscle tissue, deepening the metabolic slowdown. Mechanism 1: sarcopenia, accelerated muscle loss. Beginning around age 30, both men and women start to lose muscle mass at a rate of 3 to 5% per decade, a process known as sarcopenia. The menopausal transition significantly accelerates this process in women due to the decline in anabolic tissue-building hormones, primarily estrogen and testosterone. Muscle is metabolically active tissue. It burns more calories at rest than fat tissue does. The loss of this metabolic engine directly slows the body's resting metabolic rate, RMR. Research suggests this decline in RMR can amount to a reduction of 200. This creates a scenario where a woman can maintain her exact same diet and activity level but still gain weight, because her body's baseline energy requirement has decreased. Mechanism 2: increased insulin resistance. Estrogen plays a significant role in maintaining insulin sensitivity, which is the ability of the body's cells to respond to the hormone insulin and take up glucose from the bloodstream. As estrogen levels fall, cells in the muscles, liver, and fat tissue can become more resistant to insulin signals. This insulin resistance makes it more difficult for the body to process carbohydrates efficiently. Instead of being used for energy, glucose is more readily converted and stored as fat. This not only contributes to weight gain, but also significantly increases the risk for developing metabolic syndrome and type 2 diabetes. Mechanism 3: the shift to visceral fat. The changing hormonal milieu of menopause, specifically lower estrogen relative to androgens, triggers a distinct shift in body fat distribution. Fat storage tends to move from the hips, thighs, and buttocks, subcutaneous fat, to the abdominal area, accumulating deep within the abdominal cavity around the organs, visceral fat. This is not merely a cosmetic change. Visceral fat is a highly active endocrine organ that secretes a host of inflammatory substances, cytokines, that further exacerbate insulin resistance, drive systemic inflammation, and directly contribute to an elevated risk of cardiovascular. In postmenopausal women, visceral fat can increase from representing 5 to 8% of total body weight to 15 to 20%, creating a pro-inflammatory internal environment. While estrogen's decline receives the most attention, the concurrent drop in testosterone is a critical and often overlooked factor in the metabolic changes of menopause. In women, testosterone is produced by the ovaries and adrenal glands, and plays a vital role in maintaining musculoskeletal health and metabolic function. Testosterone is a potent anabolic hormone that directly stimulates muscle protein synthesis, the process of building and repairing muscle tissue. It is essential for maintaining lean body mass, strength, and bone density. By the time a woman reaches menopause, her testosterone levels may be only a quarter of what they were at their peak. This loss, in concert with declining estrogen, creates a powerful catabolic state that accelerates sarcopenia and makes it much more difficult to maintain or build muscle. The relative increase in bioavailable testosterone, compared to the steep drop in estradiol, has also been linked to the preferential accumulation of visceral fat. To effectively manage the new metabolic reality of menopause, a paradigm shift is required, moving away from a focus on deprivation and endurance cardio and toward a strategy centered on building strength and metabolic resilience. Strength training as a non-negotiable. Resistance training should be viewed not as an optional fitness activity but as a form of metabolic medicine. It is the single most powerful intervention available to directly counteract the primary drivers of menopausal metabolic dysfunction. Benefits: combats sarcopenia. Strength training is the primary stimulus for muscle protein synthesis, directly building and preserving the lean muscle mass that is lost during menopause. Boosts metabolism. By increasing muscle mass, strength training raises the body's resting metabolic rate, meaning more calories are burned 24/7, even at rest. Improves insulin sensitivity. Contracting muscles can take up glucose from the blood without the need for insulin. Regular strength training makes the body's cells more sensitive to insulin, improving blood sugar control and reducing diabetes risk. Builds bone density. The mechanical load of lifting weights stimulates osteoblasts, bone-building cells, helping to maintain or even increase bone mineral density and fight osteoporosis. A focus on consistency and proper form is key. A simple, full-body routine performed 2 to 3 times per week is an excellent starting point. Warm up 5 minutes, light cardio, walking, jogging in place, and dynamic stretches. Workout circuit, perform 2 to 3 rounds. Take a squats, 12-15 reps, targets the glutes, quadriceps, and hamstrings. Can be done with body weight or holding dumbbells. Can be modified by performing them on the knees or against a wall. Bent over rows, 12-15 reps, targets the muscles of the upper back and biceps. Use dumbbells and focus on squeezing the shoulder blades together. Plank, hold for 30-60 seconds. Targets the entire core, improving stability and posture. Cool down 5 minutes. Static stretching of major muscle groups. Adequate protein intake is the non-negotiable fuel for building a stronger body. Why it's crucial. Protein provides the amino acids necessary to repair the microscopic muscle tears caused by strength training, allowing the muscle to rebuild stronger. This process is known as muscle protein synthesis. Protein is also the most satiating macronutrient, which can help manage appetite and reduce overall calorie intake. Specific recommendations. The standard recommended dietary allowance, RDA, for protein of 0.8 grams per kilogram of body weight is insufficient to support muscle health in midlife women, especially those engaging in strength training. Evidence-based guidelines from expert groups suggest a higher intake is necessary. Target intake: aim for 1.2 to 1.6 grams of protein per kilogram of body weight per day. For a 68 kilogram, 150 lb woman, this translates to 82 to 109 grams of protein daily. Distribution: to maximize muscle protein synthesis, this total intake should be distributed relatively evenly throughout the day, with a target of 25-40 grams of high-quality protein at each main meal. Consuming the bulk of protein in one meal is less effective than spreading it out. Restoring comfort and intimacy. Understanding genitourinary syndrome of menopause, GSM. Amid the more widely discussed symptoms of menopause like hot flashes and mood swings, a silent and progressive condition often develops, affecting up to 84% of postmenopausal women. Genitourinary syndrome of menopause, GSM, is a term that encompasses a constellation of symptoms affecting the vagina, vulva, and lower urinary tract. The shift in terminology from the older, more limited vulvovaginal atrophy to GSM represents a crucial conceptual leap. It correctly frames the condition not as a simple consequence of aging or a sexual problem to be endured in silence, but as a widespread, chronic, and highly treatable medical syndrome rooted in the loss of estrogen. Understanding the pathophysiology of GSM is essential for destigmatizing the condition and empowering women to seek the effective treatments that can restore comfort, function, and quality of life. The pathophysiology of GSM more than just dryness. GSM is the direct result of the loss of estrogen's trophic growth-supporting effects on the genitourinary tissues. The vagina, vulva, urethra, and bladder trigone are rich in estrogen receptors and are therefore highly dependent on estrogen for their health and function. During the reproductive years, estrogen maintains these tissues it also supports the production of collagen and elastin, which give the tissues their pliability and resilience. Ensuring lubrication, it promotes natural vaginal secretions, which are essential for comfort and sexual function. This glycogen is metabolized by beneficial lactobacillus bacteria into lactic acid, creating an acidic vaginal environment, pH 3.5 to 5. This acidity is protective, inhibiting the growth of pathogenic bacteria. With the hypoestrogenic state of menopause, these supportive functions are lost. The vaginal epithelium thins dramatically, collagen and elastin degrade, and blood flow decreases. The tissues become pale, fragile, and lose their natural folds, rogan. The lack of glycogen leads to a decline in lactobacillus populations and a rise in vaginal pH to above 4.5, making the vagina and urinary tract more susceptible to infection. Unlike hot flashes, which often diminish over time, the symptoms of GSM are chronic and progressive, worsening without treatment. While dyspareunia, painful intercourse, is a hallmark and often the most distressing symptom of GSM, the condition's impact extends far beyond sexual health into daily comfort and urinary function. Genital symptoms. These include persistent vaginal dryness, burning, itching, and a general feeling of irritation or soreness that can be present even without sexual activity. The fragile tissues may be prone to tearing or bleeding with minimal friction. Sexual symptoms. In addition to dyspareunia, women may experience decreased lubrication, loss of libido, and difficulty with arousal or orgasm. The vaginal opening intrado can narrow, and the vagina itself can become shorter and less distensible. Urinary symptoms. The shared embryological origin and estrogen dependence of the urethra and bladder mean they are equally affected. Common urinary symptoms include urinary frequency, needing to urinate often, urgency, a sudden, compelling need to urinate, dysuria, pain or burning with urination, and an increased incidence of recurrent urinary tract infections, UTIs. A significant barrier to care for GSM is the fear surrounding hormone therapy, largely stemming from outdated information about systemic MHT. This fear often prevents women from accessing safe and effective local treatment. Clarifying the excellent safety profile of low-dose vaginal estrogen is a critical public health message that can dramatically improve quality of life. A stepwise approach to treatment is recommended, starting with the least invasive option. Step 1. Non-hormonal options. For women with mild symptoms or those who prefer to avoid hormones, these are the first-line therapies. 2 to 3 times per week to rehydrate the vaginal tissues and lower pH. Lubricants. These are used at the time of sexual activity to reduce friction and discomfort. Water-based or silicone-based lubricants are generally recommended over oil-based products, which can degrade condoms and may increase infection risk. Step 2. Low-dose local vaginal estrogen. This is the gold standard and most effective treatment for moderate to severe GSM. Mechanism of action. These products deliver a very low dose of estrogen, estradiol or estriol, directly to the vaginal and urethral tissues, where it binds to estrogen receptors and reverses the atrophic changes. This restores tissue thickness, elasticity, blood flow, and the natural acidic environment. Formulations. Local estrogen is available by prescription in several forms, including vaginal creams, insertable tablets, and a flexible ring that remains in place for safety profile. Because the dose is very low and it acts locally, there is minimal absorption of estrogen into the bloodstream. Therefore, low-dose vaginal estrogen is considered extremely safe and does not carry the same systemic risks associated with oral or transdermal MH. Large observational studies have found no increased risk of cardiovascular disease, stroke, or cancer with its use. It is often considered a safe option even for many breast and gynecologic cancer survivors, in careful consultation with their oncology team. Step 3. Other prescription therapies. It acts as an estrogen agonist activator on the vaginal tissues, improving thickness and lubrication, but has neutral or antagonist blocking effects on the breast and endometrium. It is an effective option for treating painful intercourse and vaginal dryness in women who cannot or prefer not to use estrogen products. Inside the vaginal cells, DHEA is converted locally into small amounts of both estrogens and androgens, which act to restore tissue health without significantly increasing systemic hormone levels. While the immediate and often disruptive symptoms of perimenopause like hot flashes, sleep disturbances and mood swings command the most attention, the most profound health consequences of menopause are silent, invisible, and develop over the long term. The menopausal transition marks a fundamental shift in a woman's risk profile for chronic disease. During her reproductive years, estrogen functions as a powerful systemic guardian, providing significant protection to her cardiovascular and skeletal system. Its withdrawal at menopause is akin to removing a lifelong shield, triggering a rapid acceleration in the risk for heart disease and osteoporosis. This makes the menopausal transition a critical window for preventive medicine. The focus must shift from simply managing acute symptoms to proactively implementing strategies that will define a woman's health and quality of life for the next 30 to 40 years. Heart disease is the #1 killer of women, and the risk escalates dramatically after menopause. The protective effects of endogenous estrogen are multifaceted, and their loss creates a pro-atherosclerotic environment through several mechanisms. Mechanism 1. Unfavorable lipid profile. Estrogen plays a beneficial role in lipid metabolism. It helps to maintain a heart-healthy cholesterol profile by keeping levels of low-density lipoprotein, LDL or bad cholesterol low, and high-density lipoprotein, HDL or good cholesterol. After menopause, this protective pattern often reverses. Women typically experience a significant increase in total cholesterol, LDL cholesterol, and triglycerides, along with a potential decrease in HDL cholesterol. This shift creates a more atherogenic lipid profile, which promotes the buildup of plaque in the arteries. Mechanism 2. Endothelial dysfunction. The endothelium is the thin layer of cells lining the inside of blood vessels. A healthy endothelium is crucial for cardiovascular health, in large part because it produces nitric oxide, NO, a powerful signaling molecule that causes blood vessels to relax and dilate, vasodilation, ensuring smooth blood flow. Estrogen is a key promoter of endothelial health, as it stimulates the expression and activity of endothelial nitric oxide synthase (eNOS), the enzyme that produces NO. The loss of estrogen at menopause leads to decreased NO bioavailability and endothelial dysfunction. This state of impaired vasodilation is considered a critical early event in the pathogenesis of atherosclerosis. Atypical heart attack symptoms in women. A critical component of cardiovascular risk management for women is education about the often subtle and atypical symptoms of a heart attack. Unlike the classic Hollywood heart attack characterized by crushing chest pain radiating down the left arm, women's symptoms can be more varied and easily dismissed. The American Heart Association warns that women are more likely to experience symptoms such as, or abdomen, lightheadedness or fainting, while chest pain or pressure is still the most common symptom for both sexes. The presence of these other signs should prompt an immediate call for emergency medical services. Osteoporosis is a disease characterized by low bone mass and structural deterioration of bone tissue, leading to increased bone fragility and risk of fracture. The loss of estrogen at menopause is the single most important factor leading to osteoporosis in women. Mechanism: the RANK-LPG pathway. Bone is a dynamic tissue that is constantly being remodeled through a balanced process of bone resorption down by cells called osteoclasts, and bone formation building by cells called osteoblasts. This delicate balance is tightly controlled by a key signaling system known as the RANK-LPG pathway. OPG, osteoprogesterone, is a decoy receptor produced by osteoblasts. It works by binding to RANK-L and preventing it from activating osteoclasts. Estrogen plays a crucial bone protective role by acting as a powerful brake on bone resorption. It does this primarily by increasing the production of OPG and suppressing the expression of RANK-L. When estrogen is lost at menopause, this brake is released. OPG levels fall while RANK-L levels rise, leading to a dramatic increase in the RANK-L-OPG ratio. This results in a surge of osteoclast formation and activity, tipping the remodeling balance heavily in favor of bone resorption. This triggers a period of accelerated bone loss, particularly in the first 5 to 7 years following the final menstrual period, silently increasing the risk for a future fragility fracture. Action plan: proactive prevention and screening. Given that these risks are silent and progressive, a proactive stance on prevention and screening is essential for long-term health. This includes annual checks of blood pressure, fasting cholesterol, lipid panel, and blood sugar glucose and HbA1c, with a primary care provider. Bone density screening, a dual energy X-ray absorptiometry, DEXA scan, is the gold standard for assessing bone mineral density. Guidelines: the American College of Obstetricians and Gynecologists, ACE-OG, and the Menopause Society recommend a baseline DEXA scan for all women at age. For younger postmenopausal women, screening is recommended for postmenopausal women under age 65 who have additional risk factors for fracture. For these women, the Fracture Risk Assessment Tool, FRAX, can be used to calculate their 10-year fracture probability. Screening is recommended if this risk is 8.4% or higher. Targeted nutrition for bone health. While calcium and vitamin D are important, they are not sufficient on their own. Optimal bone protection requires a more sophisticated, systems-level approach to nutrition. Simply delivering calcium bricks to the body is ineffective without the necessary cofactors to ensure they are properly incorporated into the bone structure. Vitamin K2. This fat-soluble vitamin is essential for activating osteocalcin, a protein that acts like glue, binding calcium to the bone matrix. Vitamin K2 also helps activate matrix GLA protein, which helps prevent calcium from being deposited in soft tissues like artery. Good sources include fermented foods like natto, aged cheeses, and egg yolks. Magnesium. This mineral is a critical structural component of the bone crystal lattice and is a vital cofactor for vitamin D metabolism and the function of parathyroid hormone, both of which are essential for regulating calcium balance in the body. Rich sources include leafy green vegetables, nuts, seeds, and whole grains. The journey through menopause is often characterized by a frustrating paradox. At a time when women most need clear, evidence-based guidance, they frequently encounter a healthcare system that is ill-equipped to provide it. The feeling of being dismissed, having symptoms attributed to just stress, or leaving a doctor's office feeling unheard and ashamed is not an isolated personal failure. It is a direct symptom of a profound and well-documented gap in medical education and a historical lack of research focus on women's midlife health. This systemic challenge makes self-advocacy not just a helpful skill but an essential one. To navigate menopause effectively, a woman must transition from being a passive patient to becoming the active, informed chief executive officer of her own health. The current menopause moment in popular culture, driven by celebrity advocates, social media, and a new wave of direct-to-consumer health companies, is a direct response to a decades-long failure of the medical establishment to adequately care for and educate women. This grassroots movement is filling a vacuum created by institutional neglect. The evidence of the gap. The statistics are stark. A 2019 Mayo Clinic survey found that only 20% of obstetrics and gynecology residency programs in the United States offered a dedicated menopause curriculum, and a staggering 80% of internal medicine residents reported feeling unprepared to discuss or treat menopause. In the UK, a 2021 report found that only 59% of medical schools included mandatory menopause education. This educational void was significantly worsened by the misinterpretation and subsequent fear-based reporting of the Women's Health Initiative, WHO. This led to a dramatic drop in the prescribing of hormone therapy and the training of a generation of clinicians who became fearful and underinformed about its appropriate use. As a result, many women are met with providers who lack the expertise to connect their wide-ranging symptoms to the underlying hormonal shifts, and are unable to offer a comprehensive range of evidence-based treatments. Effective self-advocacy requires a specific skill set, the ability to translate subjective experience into objective data, the confidence to ask direct and informed questions, and the persistence to find a true partner in care. Step 1. Prepare for your appointment. A healthcare provider has a limited amount of time. To make the most of it, preparation is key. Use a notebook or a dedicated app to track what the symptom is, its frequency and severity, and its impact on daily life. This transforms a vague complaint into concrete data that is harder to dismiss. Define your goals. Before the visit, write down a clear, concise list of the top 3 concerns to address and what the desired outcome is.